Kia ora koutou, no mai haere mai to tonight's Te Whatu Ora and Goodfellow Unit Interactive Webinar. Tonight we're going to be looking at inbox management, primarily the management of test results ordered by third parties, immunisations in the clinical context, the Pharmacy Minor Ailments Service, and we'll finish off with a few clinical updates. We're joined by a great panel of experts and colleagues to discuss tonight's presentations. Our speakers include David Maplesden, the in-house clinical advisor from the Health and Disability Commission, Dr. Samantha King, a medico-legal consultant from the Medical Protection Society, nurse practitioner Rochelle Eynon. She's a primary care clinical advisor for Te Whatu Ora and clinical editor of the Auckland Health Pathways, nurse practitioner Tamah Clapham. She's a clinical director at Health West. Daniel Tsai, the Pharmacy Strategic Development Manager at Te Whatu Ora, Dr. Tutty, a primary care advisor to Te Whatu Ora, and Dr. Luke Luck, also a primary care advisor to Te Whatu Ora. So we'll start tonight with you, David and Samantha.
Kia ora tātou. I'm Dave Maplesden from the HDC, and just wanting to kick off the discussion around inbox management with a case presentation, case from 2022, particularly relating to dealing with results ordered by a third party. So this is the case of a 50-year-old female who attended Waikato Hospital ED with abdominal pain, 11th of March 2017, had investigations in ED which included a chest and abdominal x-ray to exclude subacute bowel obstruction. She was diagnosed with constipation and possible urinary tract infection and prescribed laxatives and antibiotics. And the GP follow-up was to be PRN, no specific GP instructions. The discharge summary included reference to chest x-ray with no particular comment, and abdominal x-ray shows some right hemicolon loading. There was an 11-day delay for the formal reporting of the x-ray that was secondary to the workload in the radiology department at the hospital. And the formal report raised the possibility of a mass-like lesion in the right upper lobe, with the specific instruction, please correlate clinically and compare with previous chest x-rays with a low threshold for CT chest if there are symptoms to support, and the wording was slightly odd, but if there were symptoms to support a focal pneumonia. So 24th of March 2021, the ED Dr. C acknowledges and files the report with no further action taken. And again, this was related to workload and fatigue in terms of the provider response. The DHB comment was that safety netting was in place basically in the handling of the report, with a recommendation to make clinical correlation and consider a low threshold for CT. But of note, and I've emphasised this, further safety netting was in place as all radiology reports are sent to the patient's named general practitioner. So this was in the response from the DHB to the HDC. So they were under the impression that general practice provides a safety net for this type of situation. And interestingly, in the formal DHB policy, it acknowledges the relationship between EDs and GPs, and the policy actually stated that the GP must explicitly be requested to accept the responsibility of following up results, and that requires either a discussion with the GP or explicit delegation of the responsibility in the discharge summary. And that also, if the result suggested that urgent action is necessary, it is prudent to check that action is being taken by telephoning the GP. So in this case, there was no formal delegation of responsibility. And I guess the lesson from this is it's probably worthwhile knowing what your DHU or your Te Whatu Ora, local Te Whatu Ora policy is in terms of expectations for GPs to follow up results ordered in ED or ordered, or that they get copies of from the hospital. So a copy of the chest x-ray report was CC'd to the GP. There was no additional contact from the DHB clinicians, and the discharge summary was received by the patient's usual GP on around the 14th of March and filed. 10 days later, the chest x-ray report was received, and for some reason not able to be explained by the practice, it was received by Dr. F, who was actually new to general practice and came from a background of a few years in the hospital system, and was under the impression that, or was aware of the hospital policy, was under the impression that unless there was some explicit direction from the hospital, there was no responsibility to follow up the result. So the Dr. F annotated patchy change at right second rib region, query focal pneumonia, forwarded the comment to the usual GP, Dr. E, and Dr. E filed the result with no further action or follow-up. So Dr. E had seen the discharge summary, saw the comment from his colleagues saying query patchy pneumonia, and filed the result. Over the next 3 years, there was no new indication for Ms. A to undergo a chest X-ray, no presentation with symptoms suspicious for any sort of pathology. 29th of January 2020, she presented to ED with possible stroke symptoms, and as part of the investigation for that, there was incidental finding of advanced metastatic lung cancer. And when previous X-rays were reviewed, it was found that there was this should or may well have been detected 3 years earlier if the X-ray had been acted on appropriately. The DHB was breached for the reporting delay, and Dr. C, the ED doctor, was breached for overlooking the significance of the radiologist's comments and not following the DHB policy regarding formal delegation of follow-up to the GP if that was to be the management plan. And there are all sorts of things we could discuss around the rights and wrongs of singling out individuals when often there are systemic issues that have led to the mistakes, but that's probably not the focus of the current discussion. The general practice HDC findings, so there was an adverse comment basically around it being incumbent upon GP practices to ensure they have in place adequate systems and procedures to manage patient test results, both those, so these are comments from the decision maker who was the commissioner, both those ordered by clinicians from the practice and those that arrive in the practice from third parties, similar to the events but the events in questions reflect poorly on the systems in place at the medical centre to provide important safety netting. So in this case, the practice policy that I looked at was actually quite satisfactory and similar to those that I've seen from other practices, but there was a lack of clarity over allocation of responsibility in this particular situation when the GP is reviewing a third-party request for a patient other than that registered with that particular GP. And there'd also been some deficiencies in orientation of the GP. What was presented as my view by the Commissioner was, in any case where the result is suggestive of significant pathology that may require a time-critical response, and it is not clear who is taking responsibility for that response, both the test requester and those in receipt of the result have responsibility to ensure that it is managed appropriately and in the best interests of the patient. Sorry, that was my view. The Commissioner presented it in the final opinion slightly differently. I also expect general practitioners to reflect this in their policies, i.e. that policies will require clinicians to follow up on all abnormal test results. If the responsibility for acting on those results is unclear, any ambiguity in where any such responsibility lies should be resolved in favour of taking action on the test result and not in favour of assuming that any clinician or that another clinician will take any necessary action. So I guess the difficulty here lies in interpretation of abnormal. And, you know, so an EGFR, stable EGFR in a patient who's known to have chronic renal disease of 10 mils per minute is, you know, and you receive a copy from an outpatient with that result, it's not, strictly speaking, abnormal because it's in that specific context, it wouldn't be regarded as abnormal or an aberration from the baseline. So, so it's very context dependent, and I think in some ways the comment all abnormal test results is far too general, and as I think we'll discuss further, the context is all important. So, Sam, you are leading discussion on tips.
Yeah, thanks, Dave. Just a comment on the HDC case. I mean, in general, I agree with the comments that have been made, in particular your opinion that you gave. I think the Commissioner's comment about all abnormals is simply unworkable in general practice. And I think it does reflect a lack of understanding, perhaps, of what the realities of general practice are. And in terms of what MPS would advise, it would be use your clinical judgment. And just as Dave has said, you know, you've got to think about what's the risk to the patient. Is it really urgent? Do I need to act, or can this be left for a patient? For example, if they follow up in clinic every 3 months, the clinic themselves order the tests, they're not urgent, they're more routine, then I don't think you need to act on those sorts of abnormals. I think it's really for the significant abnormals that you really want to jump in and do something. And yeah,
the actual wording from my my opinion was exactly that. I think it is an unreasonable expectation that a GP will follow up every potentially abnormal result they are copied into from a secondary care clinician, with a more reasonable expectation being that the clinician ordering the test and receiving the result manages that result in an appropriate fashion, which includes notification of the patient where appropriate, and which might include formally deputising management of the result to a third party verbally or in writing, with that action recorded. But I guess the policies, individual policies from the DH or from the TWO regions, undoubtedly varies, and I'm not au fait with every TWO region's policy.
No, and I would, my experience or what I would see in the sector is that hospital doctors would very rarely have a formal handover of responsibility, which makes things very difficult. One other little note would be that when patients are asked to follow up with their GP, they may not. So you can't rely on them doing that. And so if you think, actually, I need to see this patient, you're best to call them in and maybe put a task up for yourself to do that. So let's move on and talk about these tips for results management. I thought we'd start with, is no news good news? Now, most of us would probably say to the patient that I'll only contact you if it's an abnormal result. So essentially no news is good news. But I think it's important to be aware that sometimes you may not have received the result and the patient has assumed therefore that it's good news. I think that for those of us that use the patient portals, it's really helpful because patients can actually go in and have a look, of course, but not everyone has that facility. So it might be important to consider an additional layer of safety for significant tests and advise the patient that they will hear from you with the result. So whether it's good news or bad news, that you're going to contact them for those significant tests that you order. And you might want to ask the patient to contact you if they haven't heard either way within a certain time frame. So that's maybe something that you can think about putting into practice. With regards to err is human, so systems must be robust. And the reality is we all make mistakes. And you can understand how it happened in that case that Dave presented, where we're busy. You've got these long reports or long discharge summaries you want to read, so you just want to read the highlights. And so often many of us will look at the conclusion of a radiology report. But unfortunately, it's not uncommon for the radiologists to put something significant in more subtle language in the body of the report and not necessarily include it, as in this case. And so we need to think about what sort of systems do you have in place to ensure that you don't miss things like this. And so maybe it is that you need to take that extra time and to read the full report or to read the discharge summary in a more comprehensive way. And think about, how do you get your inbox done in a timely manner? I know that that's a huge problem in our sector because many of you will be spending 2 or 3 hours every night looking at your inbox. But in terms of having a system for yourself where you don't take shortcuts, I think is actually quite important. Dave, do you have any comments you want to make about that?
Yeah, I think, I know there are standards for radiology reporting, which should be that, in fact, the salient and important points are included in a summary. And I do think it's a little unfair that we are expected to trawl through the whole body of some of these reports. But again, it's this whole concept of the patient, in the best interest of the patient, we do the best we can. And if we are able to look at the report in a bit of detail, then I think that ultimately works out best for the patient.
Yeah, I think that also in your region, if enough of the GPs get together, particularly through a PHO, and approach the GP liaisons, if you have one in your region, it's really good to be able to train the house officers or school them up into what it is that you need in a discharge summary that's going to be really helpful. So if they're asking for the GP to do something, follow something up, that it's very clear in there what they're asking, but also that you would have the opportunity to say no to that. So let's move on and talk about to track or not to track. That's the question. Dave, I just thought, what are your thoughts around that?
Yeah, I mean, it's really hard to have a black and white process, and again, I think it's the context is just all important. So I think if there's any suspicion whatsoever that you think this patient might have something serious going on, and particularly if you've noted that in your notes, then you really must track to make sure the appropriate investigation is completed. And there's a difference between, particularly with referrals, so there's a difference between tracking that the referral has been accepted by the hospital, for example, and tracking that the patient has actually been seen. So I've seen numerous cases where the referral has been acknowledged as being accepted, but there have been totally unacceptable delays in the patient being seen, despite in some cases the patient returning with worsening symptoms and there being no updating of the referral. And often that's based around quite a reasonable expectation from the GP's part that this patient, you've put enough information in your referral to ensure this is an urgent situation, but really not making sure that the hospital has the same impression and has seen the patient in a reasonable length of time.
Yeah, I mean, I've seen a number of cases where tracking of tasks has let the doctor down. And our memory, of course, is unreliable, especially when you're busy. So set a tracking task if it's important. And I know it takes a little bit of time to do that in the consult, but it can make a huge difference. I did have a case where a GP took a clinical photo in order to refer the patient for a possible skin cancer. The GP forgot to upload the photo to the PMS as he got distracted during the consultation, and he hadn't set a tracking task. So the patient waited and thought, oh, it must be all right. But by the time he was referred, the cancer had spread, and if the GP had set a tracking task, then it would have prompted him to look on his photos on the phone to be able to load them up to the PMS, because the GP had used the prompt of the photo arriving in the PMS as his reminder, which of course didn't happen. So just think about that, what to track and what not to track, and just use your judgment on that. In terms of enlisting the patient's help, if we pass some responsibility onto the patient, I think that's a really good thing. I think it's important.
Yeah, I totally agree. I think this is one area that we don't take full advantage of. So theoretically, every time we order an investigation, we are meant to be telling the patient what we're ordering and getting consent for the ordering of it. And I think if the patient is aware of what we're ordering and why, they may take more of an interest in the results. A patient portal solves a lot of the issues, but it's certainly not universal. And the other issue is if you receive an abnormal result and you contact the patient, I think it's important to give some information around why you want the patient to come in for a review. So I did a case recently where a markedly elevated HbA1c had been received. The patient got a text saying, oh, we've got your results back, just make an appointment sometime to come in. They thought it can't be that important, didn't come in for 6 months when they were virtually ketoacidotic. So and the argument was the patient had no concept or no realization, A, that she'd been tested for diabetes, or B, that this was an important thing that needed to be followed up. So these are just sort of traps that we can fall into.
No, that's great. So thinking about, I know time's marching on, the clinician who signs off is responsible for that result. And I know that we all sign off results for our colleagues when they're on holiday. So if you sign it off, you do need to take responsibility for it. So think about what's your system in your practice. What do you do when you don't know the patient? I know it's time consuming to go into the notes and look up the last consult, et cetera, but actually it's quite important to do that. I know that with Indicee, there's a good system that saves time in terms of looking things up. Be careful about results like PSA test results and warfarin results. I know not so many people use warfarin these days, but for those that do, we've certainly had some significant cases around PSA results and warfarin results. So if you are signing someone else's results off, please take responsibility for that quite carefully. And I know that there are many GPs who are using med students to file results, registered nurses, even some healthcare assistants. Dave, I was just thinking, because you're the in-house HDC expert, what's your view about that? That non-doctors routinely signing off results?
I mean, I've always had some hesitation around non-clinical staff dealing with clinical matters, so more along the lines of receptionists taking orders for repeat prescriptions or giving advice about results. I think probably the most important thing with the with it being deputised to other people, other clinicians or people with a clinical background, I guess, is the importance of you being confident that the processes you have in place are absolutely watertight to minimise the risk of error. And I think this whole vicarious liability issue that's been raised recently impacts even more on that, and Sam's the expert in that field. And part of that is just the vital importance of whoever is looking at the result needs to look at the patient history at the same time. So a PSA of 0.5 can easily be marked off as normal in someone that doesn't look at the record. If they look at the record and find this is a patient with a previous radical prostatectomy who needs salvage radiotherapy, if it goes above 0.4, that's a totally different situation. So there are real risks in someone flicking through and automatically signing off anything that doesn't have a red mark against it without looking at the notes. So ultimately, it's around, have you got the processes in place to safeguard against error? If they're adequate and an error occurs, you're less likely to be, I guess, found at fault than if there just weren't good processes at the start.
I think if you're delegating your inbox to someone who's a non-doctor, then I think you take a lion's share of that responsibility of how robust your protocols are, and if something goes wrong. So be very cautious about that. That would be my advice. I think we won't talk about responsibility can be delegated. I think we've really touched on that. I know that in some practices, some GPs get tests ordered in their name. And if that's you, I think the main thing is, I mean, you know, it's fine for the nurses to do that, but just be aware that it becomes your responsibility if your name's on this, if you have authorised it. I have spoken to some doctors who say that they haven't authorised this, it just happens in their practice. And if that's the case, I think you do need to speak with management about that, because tests should not be ordered in your name if you haven't authorised it. And finally, Dave, I thought I'd ask this of you. How many times do we have to chase when we are trying to get hold of patients? We've got an abnormal result, for example, and we can't get hold of the patient. What would you say? How many times?
Well, again, I think it can't be black and white. It is context important. I think the cervical smear program actually does state something like 2 phone calls and 2 letters, or there's some specific amount for an abnormal cervical smear. I mean, for me, it could be anything from, you know, a phone call and a text for some minor abnormality, to notify of a minor abnormality that doesn't, you know, that perhaps isn't that significant, to sending the police around if you can't contact somebody who's shown a blood count of a hemoglobin of 64 or something like that. So I think probably what is most important is that any attempt at contact is documented, and the result of that attempt at contact. I guess you've got to be careful about leaving messages on answer phones because of the privacy side of things. But in general, if it's something you regard as reasonably important, I would say at least 2 attempts at telephoning the patient and 2 attempts at some alternative means of contact would probably be reasonable. But it's really difficult to set it in black and white.
I think the main thing is to provide the information, preferably in writing, to the patient as to why it's important for you to see them. And then if they make a competent decision to ignore you, then that's on them, not on you. But as Dave said, you know, I think documentation is key here.
There was a quick question just around closing the loop. So I just think that was something I didn't touch on but should have, which is, I think we're looking at the third-party requests again. If the request is deputised, I think from a TWO point of view, really you cannot assume that the patient's received, the GP's received the written request, or it's gone to the right practice or whatever. So really a telephone contact confirming acceptance of that responsibility, i.e. closing the loop, is vital, and that needs to be, I think, in any TWO policy around handling or around deputising results to third parties.
We do have a question from someone just asking if the practice nurse ordering blood tests for patients if they are due, and the safety around that.
It's very normal for nurses to order those routine tests because you've set a recall for it, or you set a task for it, and generally those things have been requested by the doctor or the nurse practitioner. So don't see an issue there. It happens all the time. I think it's more those, sometimes nurses do have a lot of autonomy in terms of ordering tests in doctor's name. And I think that's where the concern arises.
Mm. And I think that there's the ideal world where we, as you said, Sam, we've got a lot of people who spend a long time trying to get through their inbox every night. And you said 2 hours, and I think that's actually a reasonable number. They can get quite overwhelming. So someone just said that it can be, it's hard enough to get through the inbox, let alone read the full report, which I think is, we do need to, it is very easy just to go straight to the conclusion.
It is.
Right.
Although having said that, I have noted that in the past, Dave, a couple of times your opinions have stated that you don't have an absolute expectation that GPs are going to read every part of a discharge summary, especially if some pertinent point is lost somewhere in the middle of it.
Yeah, I think we need to strive to make each other's jobs easier. So it means better referrals from our point of view. But I think it does mean, if there is something that a general practitioner GP is required to do to facilitate the progress for the patient, it needs to be in a dedicated, obvious part of the discharge summary. And I would be critical of TWO if it was kind of mixed up with everything else within the discharge summary, because often there's a lot of irrelevant stuff that comes in the discharge summaries. I'd like to see them, ideally half a page, or I guess if we're interested in the progress of the patient, tack that on somewhere to read if you want to. But to make our job easier and more efficient and safer, we need to have pertinent stuff emphasised and obvious and easy to access.
Yeah, and I think that means basically approaching the hospitals to say, hey, this is what we're expecting from the discharge summaries, and can you please train your junior staff accordingly?
And we've got time for one more question. So someone said that they received 10 results a day for patients not in her practice, which is, well, in their practice, which is quite a common thing as well. So what's the responsibility when patients aren't in your practice? What's your follow-up responsibility there?
Well, I've seen disasters arising from just a situation where significant results have been received, and I'm not, the practice has just said, I don't know what happened to it. We thought we sent it on to the other practice, but there's no record that it ever was, and it was probably chucked in the bin. Not good enough, in my opinion. I think it's similar to receiving a result from a third party for a test you haven't ordered. I think if it seems to be a critical or significantly important result, some effort needs to be taken and documented to ensure that that patient receives the care they require, whether that is contacting the patient if you've got details, notifying the referrer that you're not the responsible GP and they need to find the responsible GP themselves, or sending it on to the GP's practice if you know what that practice is. But some action other than throwing it in the round file needs to be taken.
We're moving on to our next session, which is Rochelle Eynon and Tamah Clapham on immunisations in the clinical context.
Ko Rochelle Takuingawa, nurse practitioner, primary care.
Kia ora, koutou, ko Tamah Clapham Takuingawa. I'm a nurse practitioner in South Auckland and a clinical director for Te Whanganui. Tonight, Rochelle and I will be presenting an update on immunisations in the clinical context. Immunisations, the big bang of our healthcare system. We're going to look at what's new in the national immunisation rates. We'll take a quick look at Beck Zero. It's been on the schedule since the 1st of March. We'll take a quick look at immunisation prioritisation matrix, some barriers and takeaways for clinic tomorrow. So while there are some positives from the recent national data in Q1 of 23, overall the national immunisation rates are still well below the 95% target of eligible children being fully immunised for their age. Childhood immunisation rates are a Tier 1 stat and are published every quarter on the Ministry of Health website. The data shows consistent inequities. The Immunisation Task Force report, which was published in April of this year, is a really good read, and in particular, the executive summary and the 54 recommendations. There's a targeted campaign supported by Te Whatu Order and Te Akawhai Order underway currently, aiming to encourage parents and guardians to keep their child's immunisations up to date. There is a new consumer website that's been launched called immunise.health.nz, as well as advertising that's been aimed at tamariki and whānau on the importance of immunisation. We do need high quality data to support vaccination uptake, for example, through identifying locations for mobile services to focus, so that AIR cannot arrive fast enough to replace the clunky NIR and the addendum of the CIR. Workforce development is also underway with new roles being trained, with new roles such as pharmacies and pharmacists being trained to deliver vaccines in the community, and improving access, especially for flu, and which is now available for all under 12 and for COVID boosters. And really the point here is to reach this 90% goal, it's going to take this collective effort from all involved. And lastly, the WIFM. So what's in it for me in terms of the primary care providers? Well, satisfaction for all of us with a job well done. If we're really lucky, a cake from the PHO, and there has been an uplift into the funding as well.
So as Tamah noted, the immunisation data here at the end of Q1 shows an overall immunisation rate at the age of 5 years is nearly 81%. However, when you look at the data further, there are clear ethnicity and deprivation inequities, which that doesn't show. Additionally, the combined opt-off and decline rate is 7.3% for the whole childhood population. So keep these in mind when we look at immunisation rates, as getting an overall immunisation rate in the early 90% is achievable. However, we saw in COVID-19 getting closer to the 95% overall immunisation rate is where the difficulty lies.
So these are the rates in the Auckland region for June. They are showing the 6-month rate. This is a really important metric for prediction for future immunisations being given on time, which is why we're showing this rate. We can clearly see the inequities comparing the ethnic groups across the region for Māori tamariki, particularly in counties in Manukau, where we can see that it's at 38.5% at the 6-month mark, and that's compared with the 61% for the total population.
Yeah, that's quite significant.
So what's new to the childhood immunisation schedule is the Bet0 vaccine. The meningococcal B strain, it's important to remember that this is the one that causes more than 80% of cases. It can result in meningitis, septicemia, and pneumonia. A separate vaccine is still required for the other strains of A, C, W, and Y, which is the Menectra. With the Bet0, it is a very reactogenic vaccine. In the under 2s, a fever of more than 88% is likely when given with other vaccines, and that's how it is on the schedule. So explaining to parents the importance of this vaccine and the protection it affords against a very serious life-threatening and preventable illness is so important. And the research shows this as well, that the confidence of the vaccinator is really important in parents' acceptability of the vaccine. And given that it is very reactogenic, this patter really matters, and the paracetamol.
So as Tamah noted, the Bet0 vaccine is widely available now. I won't go into it, it's accessible on IMAC and Ministry of Health. I think the important part here to remember is that if children aren't or are under the age of 12 months, then their schedule is as follows the schedule. However, if they're over 12 months of age, they're likely on a catch-up immunisation schedule for Bet0, and at this age group, they're very much likely eligible for their flu vaccine. So just optimising the immunisation events where they can occur, especially because concomitant vaccines are safe as well. We just need to be confident in our discussions with patients around having those vaccinations together.
And just another note that there is a catch-up that's happening for this too. And those living in specified close living situations are also eligible. So that's young people who might be boarding or in barracks, for example. And that's until 28th of February.
Yeah, that's right.
Next year, yeah.
So as Tamah mentioned, the Bet0 vaccine is very reactogenic, particularly when given with another vaccine at the same time, so concomitant vaccine administration. So a fever of 38 degrees is likely to occur. Bet0, paracetamol is recommended before administration of Bet0, but if that isn't given at the time, prior to coming in for the vaccination event, it can be given at the time of vaccine administration. So giving it at the time of administration or 30 minutes before, and then for those under 2 years, a subsequent 2 paracetamol doses are recommended 4 to 6 hours apart, and that's regardless of whether or not they have a fever ongoing.
Yeah, so there's standing orders for this available in the pathways, and it's really important to think about in the practice how this might be rolled out. I just wanted to do a quick shout out to my nursing colleagues who are independent vaccinators and also working in our outreach, who have rolled this out onto the schedule and doing catch up at speed, and there's been a lot of mahi involved in this and lots of new clinical processes, which I think off the back of COVID we've all got quite good at being agile. But again, the Panadol is really important. It is for under twos, but having spoken to nurses who are also giving this in boarding schools, even for young people, it's quite reactogenic and it's impacting on them to do sports the next day or the day after if they're sore arms.
Yeah, definitely. My child's 3 and she was definitely having a raging fever. And so just speaking as well around paracetamol, so just thinking about the utilisation of EPSO orders, so practitioner supply orders within your clinic as well, just maximising opportunities for our whānau, hey?
Don't forget pregnancy immunisations. This is a pretty big situation that we've had 3 deaths so far this year from pertussis in the first half of the year. There's been a review led by the public health and it was found to not be a more virulent strain or outbreak, but the common factor was that mothers were not vaccinated against pertussis during their pregnancy. So just a reminder that Boostrix is given from 16 weeks in each pregnancy. Those with MedTech can use the dashboard to set a recall for flu and pertussis vaccine, which is a good idea if you're seeing someone at their first antenatal visit. And as you can see from the data, we have a long way to go improving rates for all and much further to address these ethnic inequities that we can see here in this graph.
Yeah, and this is a bit of a shout out to the Best Start Callaway tools which are available as well. A joint effort between Te Aka Whai Ora, Te Whatu Ora and NHC. So they also have a antenatal assessment tool that can prompt those recalls as well that you can implement throughout your practice and clinic. However, just do want to have a look at these rates that are quite clear here. So if you look at influenza and pertussis, it's 29.6% of total pregnancies. And that doesn't mean that influenza and pertussis were given together, which can be done. And just looking at these rates, and pertussis only was 18.6 grand total. And sorry, is that Waitemata? All regions. So yeah, very poor uptake. So this is a bit of a tongue twister. Tamah and I practiced earlier. So this is the Childhood Immunisation Prioritisation Matrix tool. It's currently being used in outreach immunisation services to prioritise and address inequity. It can be adjusted depending on the presence of disease in the community as well. You know, and we just want to have a look about what this could look like for your clinic as well, not just for outreach immunisation services.
So what does the Childhood Immunisation Prioritisation Matrix mean for your clinic? Well, I think it's important to remember that this is a team effort, but it is nurse-led. Look at the administration processes, which are just so vitally important. Have a look at the matrix and think about its relevance in your practice and whether this could be a useful tool to address inequity. And in your clinic vaccination rates, so you might want to run a query build. I know that's something that we do in our practice. Be whānau-centric and inquire about other members of the bubble as well when you're vaccinating one member of the whānau.
So just looking at where the barriers to immunising might be in your clinic. So Tamah suggested mapping your clinic's process. So just see what that looks like for. So appointment scheduling, you know, are you flexible in your appointment availability? So we know most clinics are open till 5:30. So immunising up until half an hour prior to that would be most of benefit to whānau. You know, anaphylaxis is rare. IMAX support this on their website. There's information about it as well. And then also immunisation catch-up skills tools, you know, the Best Start Callaway offer this as well, and just addressing vaccine hesitancy as well. So just seeing where those barriers in your clinic do lie. And just to talk that, you know, vaccine hesitancy and conversations around vaccination take multiple discussions with patients in whānau, and they actually start early in pregnancy. So just seeing where you can have these discussions with, you know, pregnant hapu mama in your clinics, and what could it look like?
And again, I think this is something that we all learned from COVID, and those of us who did the phone calls to the community, that it does take, again, time, several conversations, different practitioners, same messaging, and addressing those other needs first sometimes can be required or fears.
Yeah, absolutely. Thanks, Tamah.
So key messages for tomorrow. It's really important to remember that most New Zealanders find vaccinating their children in tamariki acceptable, and that the many barriers have been significant in delaying on-time vaccination rates, and that the burden is on Māori Pacific and quintile 5 populations. So we do need to optimise every vaccination opportunity for whānau. And just really importantly, always accept or decline those newborn enrolments, save lives and don't leave them hanging. Lastly, this is a team effort and will require the whole of primary, community and tertiary sector to collaborate to reach our 95% target. We've been there before. We've done this and we did it during COVID immunisation most recently. We need to bust through access barriers and any clinical inertia, and that is important and literally will save lives. To conclude on this, it's team patient and we can do it. So kia ora. Thank you, Katie.
Thank you.
So we've got time for a couple of questions. So someone's just asking if it's possible that the low immunisation rates are because Bexsero has been recently introduced and the low uptake is skewing results.
That Bexsero was introduced in March, and the rates when the immunisation task force was released in April were based on the December rates, which showed pretty appalling rates then. So I think there's concern that it might increase it more, and I've seen a few cases of that already, where a baby's had quite a serious reaction and it's had quite an impact on whānau. So, and that language again that we use around is this allergic reaction or a normal expected response? Immune response. Yeah.
That language you use, you know, instead of saying a reaction, it's an expected response. Just having the confidence to support those discussions with whānau.
Yeah, awesome. And I guess someone else is just talking about the barriers again. So we're not, it's not part of the schedule for the 5 to 12-year-olds doing the Bexsero catch up. And, you know, that I guess that is quite a big barrier for people if they're living in overcrowding and there's a financial issue there where they can't afford to purchase the Bexsero. How would you support your whānau and your patients?
So there's a discussion at Boostrix vaccine, 11 years of age, that can be done. But I think it's also a discussion with the clinic that could be having had around recalling those age groups and doing it based on that prioritisation matrix tool. So looking back to see where you can be implementing that as well. I mean, a lot of these children are eligible for a flu vaccine as well, and so you could be optimising those opportunities, which we're suggesting here, because they can be concomitantly given.
Yeah, excellent. Now we're going to be moving on to Daniel Tsai. Thanks, Daniel.
Kia ora koutou. Just want to give a brief update on the Community Pharmacy Minor Health Conditions Service. This has been rebranded before the initial launch because Minor Ailments Service wasn't something that the public would be, would resonate with. So as part of the 2023 winter plan, the Minister announced the service or initiative as one of the 24 initiatives to support the communities and the health system. We wanted to ensure that the public and providers were able to encourage people to go to see their community pharmacist as a place for advice, medicine, and referral for minor conditions. Our comms teams have done a fantastic job developing some of the collateral, and that the list of minor conditions are things that pharmacists are already managing through the sale of over-the-counter medicines. But this will be a funded service looking at things like acute diarrhea, head lice, pain and fever, and some other minor skin conditions. So if you do have patients or people in the community that are looking for support from their pharmacist, you can find a list of participating providers through the Health Point website. The key goals is really to reduce the system pressures, utilising the pharmacist's skill set, improving access, because we know that pharmacists and pharmacies are open for long hours, weekends, and we really want to promote pharmacists as the first call for consultation and treatment. And we want to also note that the service is only running until 30th of September this year. The key target for the initiative is children under 14 years of age, family members of that child who presents to the pharmacy, all Māori and Pacific people, and anyone that holds a community services card. In previous discussions, we've had some queries around, do they have to meet all of these eligibility criteria? So the simple answer is no. As long as they meet one of these criteria, they're eligible and they'll be funded for a pharmacist consult. As part of the government's announcement, this has been a targeted initiative looking at areas where there are persistent pressures from a hospital flow perspective and demand. So the key district for this particular initiative is around Tsai, Tamaki Makaurau, Bell Plenty, Mid Central, Captain Coast, Hutt Valley, Canterbury, and southern areas. What the pharmacists will be able to provide will be self-care advice and reassurance, because we know some of these conditions are very minor. They don't need any treatment, but it will be good to provide parents with advice on how to relieve the symptoms, but also when they need to seek additional healthcare. Pharmacists will be able to refer through the Healthline to the patient's usual GP or urgent care, and also ED in more severe cases. And pharmacists will be able to provide a range of funded medicines and treatment aids free of charge. So for example, if it's for treatment for head lice or scabies, the funding will cover off the cost of the medicine and also head lice combs. So I've covered the minor conditions already, but there's just a list there. And it'll be important just for practices, community leaders to know that there are a number of collateral available for use within the people that you're already linking with. So there are social media tiles and posters that you can send as part of your newsletter out to your patients. There's a public website on Te Whātua, which kind of lists out all the different winter initiatives. And as part of the rollout, we did a webinar specifically for pharmacists prior to the launch date. It includes, a 1-hour webinar with a lot more detail around, which treatments are funded. But feel free to, go into that link to have a look. That's a brief update. Happy to answer sort of any queries.
Okay, thank you so much, Daniel. Appreciate that. First question, are there guidelines that pharmacists will be following in terms of managing these conditions? As often medications are not needed for some of these conditions, but it's more of a funded consultation that you'll be offering, is that right, with potential for medication? Correct.
So these are consultations that pharmacists will usually have. Even if it wasn't a funded service, pharmacists are already familiar with these minor conditions and how best to manage it. And there will be certain situations where if a condition is out of scope or more severe, then the pharmacist would be referring that onto other areas. And with the consultations, do you will you inform their family GP, their medical practice? Will you what's the sort of follow-up? Is there any? Yeah. So as part of this initiative, because it is still a proof of concept, there isn't a direct link or integration with general practice. However, pharmacists will maintain their own clinical notes. If they do have any medicines supplied to the patient, it will be with like a named label that will be uploaded onto your regional medicine data repository like TestSafe.
Yeah, perfect. And sorry, can I just confirm they're funded? So that means that patients don't have to pay for them at all, or what's the...
Correct. So patients won't have to pay as long as they've meet the eligibility criteria and it's part of the minor conditions listed, and that will be free of charge. So for example, for pain and fever, pharmacists may supply paracetamol suspension or ibuprofen suspension. They'll be able to provide a syringe free of charge. And then Te Whatuara would be funding the provider, which will be the pharmacy, for the consultation and also the drug cost.
Oh, excellent. That's awesome. And I'm just checking. So the whānau members, does that include extended family or those living in the household, or what's the definition? Would you,
Yeah, so I mean, this will be for direct family members, and of course, understand that for conditions such as head lice or scabies, if you do have extended families living in their household, then it would be appropriate to treat the whole household.
Okay, awesome. Is there anything else that you would like registrants to know about, or?
No, I think the main thing is just really have a chat with your local pharmacist, see how you can work together. We've already started to see amazing examples where the GP and the co-located pharmacies are working together. They've got a good system of just making sure that common minor conditions can be managed at the pharmacy setting, and hopefully that will help to relieve some of the congestion in waiting rooms.
Yeah, awesome. And I think it is really important to have that relationship with your local pharmacies and your local pharmacists, I should say, because it is such an important dynamic that we have there.
Yeah. So we just appreciate getting a message out, and there'll be a lot more comms messaging going out to the public, including things like messaging to early childcare centres and schools.
Excellent, awesome. We do have another question that's just popped through. So would pharmacists use ethical medicines, or will they be able to use charged allopathic substances which are high cost and low or zero efficacy? Is there any conflict of interest that you can see? I'll just move on to the rest of the question. Is there any conflict of interest you can see with pharmacists providing funded medicines or medicines that, I mean, I guess there's a very particular subset of medications that if you are providing, you will be providing those. It's not like you'll be giving.
Yeah, correct. So as part of the initiative, we have defined, which approved conditions are considered minor. We've approved a list of medicines that are listed on the pharmaceutical schedule. So these are medicines that would usually be funded, so low cost items. And I guess, the goal was that, we didn't want people to have to go see a GP just to get their, head lice treatment prescribed in order to get a funded or free consult.
Yeah. And will the pharmacist be doing any like baseline recordings such as temperature or pulse or anything like that? Is that sort of part of the consultation?
So that would just depend on the sort of condition and the severity. But I guess I want to add that, as part of this initiative, we do want to evaluate it. So all the pharmacies participating in this program they're recording some really good data, and then we will be trying to link that up with like general practice and ED utilization, just to measure whether an impact has been made or not.
Okay, awesome. Thanks, Daniel. I really appreciate that. Someone's just asking if the service is available in the Waikato. I do apologize. I can't see the list of.
No, so unfortunately that's not in the Waikato area.
Lovely. Well, thank you so much for joining us tonight. If there aren't any more questions, we'll move on to our next topic. And that will be clinical updates with Dr. Sue Tutty and Dr. Luke Luck.
Luke and I have worked to set up this webinar series with the aim to just share some information of changes that are happening in clinical care. There's a full list of the primary care advisors across Metro Auckland that's available on the Auckland Regional Health Pathways. So if you go to Auckland Region Primary Care Advisors, you'll see a list of all of us. And it also includes our areas of interest so that you can email the right person about the right topic. But if you're not sure who to email, just email any of us and we'll pass on the information. So there were a couple of little updates that we wanted to do tonight. For the counties area, we were just going to let you know that for children with pneumonia, it is no longer required that you need to ring for a paediatrician for advice before you order a chest x-ray. However, I would still remind you that in pneumonia in children, it's mostly a clinical diagnosis and there is little place for a chest x-ray anyway. There are some indications that are there on the pathway, and there's also the symptoms and signs that you should be looking for to make that diagnosis as well. So just that's a new change without requiring you to ring a paediatrician. Another thing I would want to just mention is that I've just been doing a bit of an audit looking at some of the prescribing for people with diabetes. And just a quick reminder that if you are starting someone on dulaglutide, please remember to stop the vildagliptin at the same time. So that's if you're starting Trulicity as its other name, that we stop the Galvus. It's not that they cause a problem if you're prescribing both of them. It's just that they work down the same pathway, so the vildagliptin becomes redundant and won't do any good. So you are potentially exposing people to side effects from the vildagliptin that they don't need because it's not actually helping them at all. So there's lots of really useful information on that pathway if you want to have a look at it with some of the new guidance that's come out from NZSSD. Okay, I think that that's about all that we had to say tonight.
We've just got one coming in from May, and are you losing funding for the empagliflozin?
Losing funding for it, not that I'm aware of, no.
Lovely. We've just got some more questions just around the empagliflozin and Trulicity. Is there anything else you wanted to sort of mention on that, Sue?
I think that we've seen amazing results with these new medications, and that I'm hoping that everybody's getting very familiar with them and the special authority that's required. Unfortunately, you cannot prescribe both under the special authority, but you can offer both to your patients. They would need to pay for one of them if they were to use both. But there's no reason why they shouldn't use both medications if it would be appropriate for them.
Well, if that's all for tonight, I will just bring the webinar to a close. So I just want to take the time to thank all of our wonderful presenters for coming on tonight. And thank you so much to everyone for joining us tonight. Have a lovely night, everyone. Keep safe. Ka kite.